Yes, my name, I'm called Owino Opudo. I work for Goldstar Kenya. I'm representing Goldstar Kenya, which is a consortium for the USAID Tujenge Jamii project, which is implementing HIV care and treatment in 4 counties, our main county being Nakuru County. So I will be presenting an abstract, and this abstract is entitled The Impact of Continuous Quality Improvement on Retention, and here we are focusing on continuity of treatment amongst patients who are living with the HIV. And this was a case study which was done at Naivasha Sub-County Hospital, Nakuru, Nakuru County, Kenya. And here we were looking at patient retention, which was defined as continuity, as continuous engagement of patient in care, which is a bit crucial when it comes to HIV care treatment outcomes. And we also identified that there has been suboptimal patient retention to care, which has been one of the challenges, especially for ART programs within many settings. And therefore, we felt like ART programs still need to come up with the solutions to identify and come up with interventions to improve on their retention levels. So looking at the objectives, our main objective was to address retention gaps through continuous quality improvement approaches, and also develop some form of framework to improve patient retention in care based on interventions implemented in health facilities that have achieved higher levels of retention in care. So for the methods, USAID Tujenge Jamii, in collaboration with the Ministry of Health, conducted a baseline continuous quality improvement survey, which was done in August 2021, just before we transitioned to the new program, which is now called the USAID Tujenge Jamii, to just try and address appointment keeping and differentiated service delivery uptake amongst adults, adolescents. That one we were targeting. We were looking at the ages 10 to 19 years and the pediatric recipients of care. So the intervention entailed a simple, it entailed quite a number of interventions. However, in summary, it entailed proactive retention strategies, which included phone call reminders as well as SMS reminders 3 days prior to the clinic days. We also conducted default tracing within 24 hours with accelerated case management, again, amongst our patients. And there was also a series of community ART distributions and also return to care packages for patients who had interrupted treatment. And this was done with fidelity. Other than that, we also conducted routine data reviews for a period of 6 months. And here we are looking at data. We are looking at we are looking at a follow-up for the next 6 months after we had done our baseline survey. We also did a Pareto analysis again to just identify the vital few reasons from the useful many which were the common causes of treatment interruptions to inform our interventions. And just to give us a heads up of the steps which we took regarding the CQI approach, we first of all did gap analysis, and through gap analysis, we employed a mechanism such as brainstorming mechanisms. Then for the situation analysis, we did it through the Pareto analysis, which I'll be describing to the rest of the team. And then we did a root cause analysis, again through the 5 whys. Then our 4th step, we came up now with the interventions which I had already mentioned earlier, and then we implemented them with fidelity, then conducted routine data review to actually look at the progress. Then after that, we also came up with our lessons that we learned. Those that we adapted, there was continuity, and those ones that didn't work for us, we abandoned them. So looking at the results, thank you. We noted that there was a significant improvement in terms of appointment keeping from a baseline of 95% to a baseline to 98% keeping among the adults. And again, among the adults, again, remember, since they already been initiated on ART, we are supposed to transition them to different categories of differentiated care service delivery. So again, there was also an improved uptake in terms of BSD from a baseline of 27% to 85%, sorry. And again, this was also followed by the adolescents, again, from the ages of 10 to 19 years, who also improved in terms of the appointment keeping from 92% to 100% and 94% to 100% for the pediatric aged 0 to 9 years. So looking at these significant improvements, again, they were also attributed to the scaling up of an intervention which we term as Operation 000 for the adolescents, and also caregiver module training which was done for the healthcare workers as well as the adolescent champions within our facilities. Looking at the situation analysis, we did an analysis of about 111 clients, of which we wanted to find out on the reasons as to why they had treatment interruptions. Among them, looking at the vital few, we had 30 clients who had forgotten their TCAs, their dates of return. 22 of them said that they had busy working schedule, as well as 16 of them said that they had other reasons. 14 cited transport issues, as well as distance. However, despite this attrition, we also noted that there was also a significant increase in terms of the number of patients who are living with HIV, whom we had enrolled in our facility and who are also active by that time, from a total of 3,074 to a total of 3,100 as at end of April, which was a 95% achievement against the project's target. So in conclusion, we feel that CQI, that is continuous quality improvement, as well as client characterization, it will help many programs with remodeling their clinical service delivery, and also use of EMR modules, which you also used as a part and parcel of the methodology, also contributes to our appointment keeping. It is also cost effective in terms of appointment reminders, and also helps us with developing psychosocial support groups, especially for the newly identified clients.